Welcome to World TV Day from the Heartland News Desk. I'm Dr. Barbara Seaworth, and I, Dr. Lisa Armitage, will be going over some of the timely topics that are happening in TB right now. For starters, we are all coming out of a pandemic, and we are hoping that things are going to go forward for us and that we will be moving on with our lives, coming out of some pretty kind of distressing places. So looking at it to move forward, we need to look at what impact the COVID-19 pandemic has had on our TB numbers and deaths, so we know how to best address what we need to do with our patients going forward. It became pretty evident last year when they started looking back at the 2020 numbers that there is a huge impact on the number of TB diagnoses worldwide. So we're looking at a 23% decrease in the number of TB cases that were reported from the 9 highest burden TB countries. And we looked at the numbers in the US and same thing. So we're looking at our numbers and there's a big drop off at the 2020 point. So the first thought is, okay, well, many of our TB cases are in foreign-born individuals. Maybe we shut the borders and that kind of shut things down. But when we're looking at our decrease over time, we have a huge drop-off at 20%. When we looked at the US born versus non-US born individuals, absolutely the same. So it wasn't that we shut the borders, and it wasn't that people were coming in with the rates from their own country. This is happening right here among our own individuals, where our own US born individuals and non-US individuals are dropping off the same. So then the next question is a disproportionate number of individuals in any race, any one group of individuals. And when we looked at the numbers for just the number of cases per ethnic group, it looks pretty similar, but when we actually look at the percent of cases within each ethnic group, 2018, 2019, 2020, all look absolutely identical. So across this pandemic has hit carte blanche across every ethnic group, every individual that is in our country. We've touched it. We've touched everybody. And then most distressingly, the number of deaths. For the first time in over a decade, we have increased number of TB deaths. And the World Health Organization estimates an extra 500,000 people died of TB in 2020 that did not need to. Next, we're learning that we have hit our most vulnerable, our children. So this was a release that just came out about a week or so ago. And in 2020, it's estimated that 63% of children and young adolescents below 15 years of age were not reached with the medication they need, or not officially reported as having disease. They were not diagnosed and even offered the services that they needed. When we looked at children under 5 years of age, 72%, even higher proportion of them didn't receive care. And then, so that leaves all 2/3 of eligible children under 5 who could have received TB preventative treatment because they were in the house with individuals who were infectious. These children did not receive the medication that they needed to prevent them from advancing to active disease. So why? Why was this such a devastating lick on what it is that we were trying to do? Lockdowns. So lockdowns was one of the most impactful factors globally. We don't really think about it now like we did before, but when everybody was at home learning how to break sourdough bread and confined to their homes, we were missing a lot of the cases of individuals that should have been able to get into care. Patients were fearful of seeking care. I remember initially there was no COVID entrance and a not COVID entrance. So people who had chest pain, if they didn't have chest pain really bad when they showed up and saw a long list of people coughing, they would just go home and see if they could just ride that out. So people were fearful of seeking care, and even when they did, just tested repeatedly for COVID-19 and not looking at other things that this could be. So once a person tested positive for COVID, everything became COVID. Just ignore that cavity in their chest, and that COVID doesn't do that. Let's just, they had COVID. And so you wanted to get them out. You had a diagnosis, you sent them on. Diversion of funds for COVID-19 response. We didn't have a penny extra for public health dollars. Now all of a sudden we've got money flowing, and it's COVID money. Like it's like we're playing with Monopoly money. We have money that is just raining down like manna that we did not have before. And so there's the funds had to come from somewhere. And so I have not seen that in TV. Maybe some of you have, but then the diversion of our staff have been rerouted from TB and STD and HIV over to responses for COVID. So we have seen, and I know that in our region here at Heartland, we've seen a lot of people, individuals who are really stalwarts in the TB community that have retired over this time. And we have lost had some attrition of some of our nurses. So the question with what is happening in 2021, the numbers haven't come out, and I'm hoping that by the time we're online, we will see some numbers coming in from the CDC. But right now, we looked at our numbers here at the San Antonio Chest Clinic, and we broke them out according to quarters. So we had a 42%, 41.5% decrease in the number of cases of number of TB patients that were determined to have tuberculosis. We went from 96 cases in 2019 to 56 cases in 2020. And then we looked at the quarters. We started off before the world went wonky. In Q1, we had the same number of cases. And then all of a sudden in Q2, it dropped off. And when we should have been seeing our usual rise, which was our pattern, we always get a few more diagnoses in the third quarter. And our clinic closes for the holidays. So we have 10 days off at the end of the year. And so a third of the patients that we may have seen probably would not have been diagnosed. And a lot of people will stay home for the holidays and won't want to go to the hospital, et cetera. But there was just a flat line. So we saw basically the number, that was our baseline number of cases. Then we started seeing in 2021, the numbers rebounded. And did they rebound? So they never really touched where they were in 2020, in 2019, but the numbers did come back up. And we were finding these people are sicker, and they have more disease, and they have been diagnosed with COVID over and over. And then now suddenly they're determining, well, okay, that's kind of long, like 6 months is a long time to have COVID. So maybe it's something else. And so now we have our patients coming in that have advanced disease. And then in 2022, we have already have matched what we have as our highest number for the quarter in the last 4 years. But we have 17 more patients to match those that are currently under evaluation. So the thing is, the numbers are coming. And importantly, the things we don't know. What effect does the treatment for COVID-19, the steroids, the malnutrition, basically from being so sick, the stress of severe disease, what effect does that have on the reactivation of TB infection? Where are these missing TB cases now? And how will their reintroducing into care impact our available resources in the coming years? How do we optimize our efforts to ensure that these patients who have disease and TB infection that were lost are brought back to care and taken care of? And what effect will public health burnout play on getting TB care back on track? So there are many things that we do not know and things that we need to be considering. But in the meantime, I ask the question, my patient is better on treatment. Now the lymph nodes are bigger. The patient was getting better. The lymph nodes are bigger. The pleural effusion is back. She doesn't have HIV. Dr. Seaworth, what is happening with my patient?
This could easily be something called immune reconstitution inflammatory syndrome. Well, what is TB, non-HIV iris? We all know about TB HIV iris, but for non-HIV, we don't have a precise definition. We don't have diagnostic criteria we've agreed on. What we can say is it's characterized by an exaggerated and dysregulated inflammatory response, and it's caused by reconstitution of the immune system. It's a shift from an anti-inflammatory pro-inflammatory type of response in an individual person. So how is non-HIV iris manifested? in two different ways. You can have either unmasking iris or paradoxical iris. With unmasking iris, the disease becomes newly apparent. It was there before, subacute, unrecognized, untreated. But once the immunity improves, the immune reaction improves, now you can recognize that there is active infection going on, and the diagnosis of unmasking iris requires a pathogen to be identified on culture from new lesions. As opposed to that, paradoxical iris is a TB infection already diagnosed, already on treatment, and the person is improving clinically. But then all of a sudden, paradoxically, they worsen, even though the disease is being correctly treated. It's a diagnosis of exclusion. You must make sure that you don't have treatment failure. You must make sure that there isn't another infectious disease that's there with the TB that's causing these worsening symptoms. But once you've done that, you may have a paradoxical iris reaction. So what are some triggers for non-HIV iris? Well, simply starting TB medications in an individual that may have had long-standing tuberculosis, extensive disease, may be sick for a long time, malnourished. Once they start on TB therapy, it can improve their immune responsiveness and their ability to react with an inflammatory response. Or a trigger could be that there's a recovery from the immune suppressed state because of abrupt tapering of steroids, the withdrawal of TNF-alpha blocker therapy. The postpartum state is a normal state that occurs shortly after delivery when the individual's immune system strengthens quite quickly. Some people propose that probably even initiation of dialysis will improve the immune response in some patients. So if we look at the clinical presentation of unmasking iris, remember this is a patient in which we don't have a TB diagnosis, they're not on therapy, they're just kind of not well. But all of a sudden they present with an abrupt onset of cough, shortness of breath, fever, night sweats, where it could be new abdominal pain, new ascites, new chest pain, new pleural effusion, new neurological symptoms, or draining neck lesion. But this is an acute presentation rather than a smoldering chronic infection. For a paradoxical reaction, the clinical presentation, remember this is a patient on therapy who is getting better. And now the fever comes back or it worsens. The cough comes back or it worsens. Now, they may develop new shortness of breath. There may be a new or worsening pleural effusion. They may develop new ascites, or the ascites they have may get worse. The lymph nodes they have may increase in size, become fluctuant, drain spontaneously, or you could have a lymph node appear in a completely different area. You could have new neurological findings. The X-ray may look worse, and you can have a new lesion in a completely previously uninvolved organ. There aren't many reviews. There are a few case series, case reports, but this was one small review that I noticed. It was dealt with only pulmonary non-HIV iris. It was and they looked at infections that occurred that they believed were due to non-HIV iris. The most common one was 17. It occurred in 17 different individuals they were able to identify in case reports. They were able to find 9 cases of histo, 5 of aspergillosis, and 4 of cryptococcus. But TB, as I noted, was the most common. It occurred in 14 of the 17 instances in those with TNF-alpha antagonist recipients, and in 2 cases in those with solid organ transplants. It occurred anywhere from 10 days to 3 months after the period of reduced immunosuppression resolved. 10 of the cases were a paradoxical reaction, and in 6 there was unmasking. This is something we're all familiar with. This is a paradoxical reaction. I saw my first one well over 30 years ago taking care of TB. It's when the lymph nodes get worse despite appropriate therapy, despite curing your patient, the node it gets bigger. It may even rupture and drain with a draining fistulous tract. Now, if you can aspirate it, you may be able to prevent that fistulous tract. This, unfortunately, picture shows two different individuals who, despite encouragement, did not come in for needle aspiration. And this is what you can be left with in this particular situation. Another example of paradoxical iris in non-HIV infected individuals that we're all familiar with is that which occurs with central nervous system tuberculosis. And in fact, it's the one time where prevention strategy is recommended because this has occurred so frequently. Routine steroids are recommended. However, they note in the most recent guidelines that they should be tapered over 6 to 8 weeks. And this is way too soon for some individuals, and they will have recurrence of initial symptoms, enhanced or CNS lesions, and most people will respond to reinitiation of high-dose steroids, although sometimes patients, once this inflammatory reaction gets started, may have to even be treated with TNF-alpha blockers. This is a patient that walked into my clinic about 9 months ago. She had miliary TB of her lungs and omentum. She had prior rheumatoid arthritis and had been treated for quite some time with a biological agent. However, it had been stopped 2 months ago because her doctors thought she had some type of infection. Evaluation showed non-caseating granulomas on lung biopsy, and nothing grew. So they thought this must be fungus. So they treated her with antifungals for a month. She didn't get better. They did another diagnostic procedure, same thing, non-caseating granulomas, nothing was growing, and they go, must be possible sarcoids. So now she's off of her biologic for a month, and they decided to start high-dose steroids. So she's treated with them for a month, and then her TB culture is positive. They suddenly stop her steroids. That was a Friday. Monday, she appears in my clinic, and she's very short of breath. She has this very nasty chest x-ray with diffuse infiltrates. She describes not being able to eat because it's hard to breathe and eat. She can't take a shower by herself. This is a young, healthy, previously very physically fit young woman. And her oxygen saturation was good, but she was working really hard to breathe. I suggested to her that we call her doctor and she consider a short period of hospitalization, but she refused doing that. So I thought that there was some iris reaction going on here, as well as her TB treatment or her TB infection. So I started her on steroids and I gave her 30 milligrams of prednisone. I said, if you get one little bit worse, you need to go to the emergency room. Well, about a day and a half later, we heard from her again, or we reached out, and she was slightly better, certainly no worse. And when I saw her at 4 weeks, her chest x-ray was significantly improved. She was able to talk in sentences. She had gained some weight. She was eating. She was still short of breath, but much less so. And I think that we were treating her TB and her iris at the same time. But again, we don't have diagnostic criteria. So I can make a case for this, but I can't prove it. Another time when we see the possibility for an iris reaction is in the postpartum state. Pregnancy is a state of subtle immune suppression, especially the third trimester, and then postpartum, there's a rapid return to a pro-inflammatory state. It can happen as early as several days, certainly by 3 weeks. If you look at patients with TB, which is diagnosed during pregnancy, most of it is pulmonary. It's extrapulmonary, only 5 to 10% of the time. But if you look at TB that's diagnosed in the immediate postpartum period, it's often extrapulmonary. Most of the time, in fact, in this one series, it occurred in 93% of patients, and 69% of them had CNS system TB. So if you're seeing a TB patient in the postpartum period, think about where else might your TB be other than the lungs? And if there's any consideration for some kind of CNS involvement, please do additional imaging and testing. This is a really sad case. This is a young woman who just really wasn't quite well during her last trimester of pregnancy. She was working up until the time she delivered, but she was just feeling really, really not strong, not well, very fatigued. She was getting more anemic. Her albumin was decreasing. But a month postpartum, she presented with fever, fatigue, shortness of breath, night sweats, rare cough, more anemic, and lower albumin. Interestingly enough, the skin test was very positive during the initial trimester. She was again skin tested about a month postpartum and was now had a TST of 0.0 millimeters. She had multiple clinic visits in that first month postpartum. And then at 6 weeks, she went to the emergency room, short of breath, tachycardic, with fever, cough. COVID, of course, was negative. The chest x-ray, no chest x-ray was done, but when she went back at 7 weeks, she had similar symptoms. And now a chest x-ray was done and it was read as diffusive pacifications consistent with mycobacteria or fungal infection. But she was COVID positive, so they sent her home. And at 13 weeks, she went back to the emergency room. This time she looked septic. Her O2 sacs were less than 90. Her T-spot was now positive. AFBs were 4+ in sputum and urine. Her albumin was 1.7. 2 days into her hospitalization, TB was diagnosed. She was on therapy for a day, then she arrested. She had CNS herniation. The sites involved included lungs, lymph nodes, brain, adrenals, ascites, kidneys, myocardium, and a positive blood culture. I think she had unmasking iris. TB was smoldering in the third trimester. She actually presented with a large, very large breast abscess at the time of delivery, and the day after delivery, it was addressed surgically. All cultures were negative. That breast abscess was still present at the time of her death. So we don't have any specific treatment for non-HIV iris. There's no guidance. Everything is based on the patient's individual case. It varies from observation to high-dose steroids to TNF-alpha inhibitors. The duration of therapy is unknown, and we don't have any prevention measures either, other than the standard give steroids with CNS TB.
Okay, so now we've talked about, the numbers with our patients. We've talked about how we're having some interesting presentations that we need to consider, but it's been a long time and we've been with the same treatment regimen. So isn't there a shorter or newer or shorter treatment option? The answer is yes. We have study 31 that has now been actually published. But I wanted to bring this slide up from the tag, one of the tag documents, just to point out, look at the bottom of the slide, the duration of treatment. We've gone from 24 months when we were just giving isoniazid, and especially early on streptomycin, we were just giving injections. And we're all the way down now to a point where we have a regimen that we should be able to cure people within 4 months who have drug susceptible to tuberculosis, and in 6 months, patients who have drug-resistant tuberculosis. So I wanted to talk about treatment shortening with drug-sensitive TB. And 4 months of ribapentine regimens. They did with or without moxifloxacin for tuberculosis, and we discovered that if we add moxifloxacin, we can get non-inferiority compared to our standard RIPE for 2 months, and followed up with rifampin and isoniazid for 4. And so the nice thing about this particular study was that they actually enrolled patients that were living with HIV, but also the larger proportion of patients had cavities on chest x-ray. So this wasn't just a study of people who had minimal disease. These were actually people who had significant amount of disease, and we show efficacy. One thing that we need to consider, so the first thing you want to look at is when we start a patient who is 70 kilograms on RIPE, that's 12 pills. It's already a lot of pills. And then they drop down to 4 pills if you count the 1 isoniazid, 2 rifampin capsules, and 1 pyridoxine or vitamin B6 capsule. But the numbers for if you're going to treat with the new regimen are going to be significantly higher. So it's a shorter period of time. We shave 2 months off, but we're giving a whole lot more pills. And mostly this is represented by the 8 tablets of rifapentine. You want to be honest with your patient up front. It's going to be a lot of pills. So the safety and efficacy, I would encourage you to look at the paper. This is also pulled out of the TAG document that's talking about it. You lose about 2 percentage points in favorable outcomes and gain 2 percentage points in unfavorable outcomes, but they are close together and non-significant. So, and also looking at the grade 3 or higher adverse effects, all-cause mortality, looking good. So we've got a regimen finally after so many years that we can move forward with and treat our patients. And just looking at the bottom, this is a study that was a joint effort between the TB Trials Consortium and the AIDS Clinical Trial Group. So we have a whole set of kind of pull out, looking at our data in HIV, and it looks equally as efficacious. So now, who can we use this on? So now we have a regimen. Who can we use it for? So already we are hating on our little people, and y'all know I'm a pediatrician, so I'm always a little bit miffed, but any child over 12, so our adolescents are included in the group this time. And any individual person over 12 years of age have to be at least 40 kilograms. That's where we started the measures at. Pulmonary TB, yeah, none of our patients have just pulmonary TB. They're not known or suspected to be drug resistant. If they have HIV, they have to have a CD greater than or equal to 100, and then either receiving or planning to receive an efavirenz-based antiretroviral therapy. This might lead to some problems right there, but still we have one group that we still have a significant number of people who we can treat with, but they have to have no significant drug-drug interactions. So I will tell you, rifapentine and rifampin are blood brothers. They do the exact same type of things when it comes to firing up your liver to destroy everybody else's drugs. So that needs to be taken into account of what medications a person's on, because a lot of times we get a little grace by changing rifampin to rifabutin and trying to cut down on drug-drug interactions with things like warfarin, oral contraceptive pills, things such as that. But we don't have that option. The linchpin of this regimen is going to be having rifapentine at a high dose. So absolute not recommended for less than 12-year-olds. My little people are left out, less than 40 kilograms. Pregnant or breastfeeding, I look at that as an assault on the babies even before they make it out of the womb. So we don't even have treatment for that. More to come on that. Most extrapulmonary TB, in likelihood, there's some discussions about going either way with that. But if you think like bone and CNS, the manifestations of TB that needed to be treated for a lot longer, we don't want to give 4 months to someone with CNS disease. So that would not be a good choice. And bone does take a lot longer to cure. So if there are parts or places that it's a little harder to cure, you probably don't want to pick this regimen. They have a history of prolonged QT syndrome or QT prolonging medications besides the moxifloxacin we're going to be using. You may want to rethink that one. Drug interactions, obviously, or resistance to medications in the regimen. So if you think about Imbovis, which is naturally resistant to PZA, this is not the regimen for that. And unfortunately, there are physicians out there that give out fluoroquinolones like Tic Tacs, and you always, if you have a patient who has been on a fluoroquinolone repeatedly for recurrent UTIs, for example, you may want to be a little anxious about whether you or not you want to use this regimen, not knowing for sure that they are susceptible. So what's required to do the regimen? To start off, baseline assessments. You have to be able to do a microbiologic, laboratory, and clinical assessments of the patient. So you really need to have a bug. Not absolute. There's some wiggle room if the person is culture negative, but we have a 4-month regimen with a whole lot less pills, a whole lot less expense, and a whole lot less monitoring that already works. So if you have a patient with minimal disease and they're smear negative and culture negative, you might want to consider whether or not you want to use this regimen. You need a respiratory specimen for AFB smear and culture, and you need to draw that at baseline, and you also need to do that monthly to make sure that the person converts. You have to do have access to molecular drug susceptibility testing. This is a short regimen, so we don't have all day to be figuring out if this person is susceptible to the meds. The rifampin is the most important. Rifampin is going to be used as a marker for whether or not rifapentine is going to be susceptible. But at the minimum, you need at least molecular testing for rifampin in the beginning. And you need to follow that by phenotypic drug susceptibility testing so that you know all components of this of the regimen were susceptible. So administration should be administered with food. Most people don't mind having a snack, but has to be done 7 days a week. At least 5 of those need to be observed, but really this is a commitment. If you're going to sit down and talk to the patient, you have to tell them this is a commitment and you need to do 7 days a week. You can't be having a weekend in South Padre with your buddies and have a drinking binge. We need to be focused for a whole 4 months because we have a short period of time to get this done. So what's considered completion? Everybody's like, what do I need to do to complete? 119 doses, and it is dose count, just like we do with the other regimens that we have in TB. It is based on dose count. You have to have 56 intensive doses in 70 days, or you have to have 63 63 continuation doses in 84 days. So essentially you have 5 months to complete the entire 4 months of treatment. So again, want to have a vacation, I need some time off, I just need to clear my head, this is not the regimen perhaps for you. Definitely want to have a sit down chit chat with that patient in the beginning about commitment. And then at the end, you have to have confirmed that they have continued drug susceptibility throughout the course of the treatment. This is all from the CDC document that came out giving some recommendations. This was the preprint that came out in the MMWR about the regimen. So you might want to consider a consultation if in the past 6 months, the patient has had more than 5 doses of treatment for TB disease, more than 5 doses of treatment for TB infection, and more than 5 days of treatment with either INH, rifampin, rifabutin. I can think of a patient who was suspected of having MAC, maybe getting rifabutin, rifapentine, PZA, or any fluoroquinolone for any reason. So if you consult with me, I would probably on a case-by-case basis look at your patient and suggest if there's no reason why the regimen shouldn't work. I think it's probably a go. I'm just going to throw that out there. Don't everybody call me all at once, but call your COEs and at least chat with someone who has a little bit of experience with these. But in all likelihood, you're going to be okay. Laboratory abnormalities at baseline that are elevated, you may want to consider at least for the patient. Sometimes we've seen the patients with a high liver indices, and sometimes it's the liver that's involved with the disease itself. Or the patient's been in the hospital receiving who knows what. I love that Tylenol for fever. No, don't do that. But a lot of times patients get a lot of things in the hospital and their LFTs will come down when they come out of the hospital. Or again, if you have disease and you think it's somewhere tickling your liver and the LFTs are elevated, maybe you're a go with this. But anyone with advanced liver disease, remember you have to have 2 solid months of PZA. You have to have a long time, and that's kind of a hard drug sometimes. Renal insufficiency or end-stage renal disease, there weren't really any guidance on how to dose PZA in these circumstances, but if it works for the standard treatment regimen, you may have to consider whether you want to drop the dose down for that. But some challenges to consider: pill burden. Pill burden is not a trivial thing. The patients have a little party the day that they get to drop down some of their numbers of pills when they're found to be drug susceptible. So tolerability, most patients, we know that it's safe and efficacious. It's just a matter of they're going to be able to tolerate 2 solid months of PZA or that many medications. Are they going to get pill fatigue? Familiarity with the regimen. We know how each of the drugs in rifampin, isoniazid, PZA, ethambutol is like in our sleep. We know all those side effects and toxicities, but probably going to be a little bit of a learning curve in trying to figure out some of how this regimen is going to work and what kind of side effects to look for. The question of whether you need an EKG. You do have to ask the patient some questions about lightheadedness, dizziness, palpitations, and things, and wonder about whether you have long QT. There's probably a 50-50 split on physicians who are going to want to do an EKG and look and measure the QT interval, and then another 50% that are comfortable with the moxifloxacin and say no. Rifapentine availability, I pulled this off this morning from the FDA website, and shortages seem to come and go, but also the availability of rifapentine in some of the regions of the country has been a little spotty. You definitely want to make sure you have all of the medications that you need to complete the regimen before you start the regimen. So things we don't know. What if all doses aren't completed in the required time? What do you do? So what if the patient is culture positive after greater than 2 months of the 4-month regimen? I would say extend the regimen, but that's not something that was necessarily studied. What if the patient gets pregnant during the course of treatment and we have no data on pregnant ladies? And this is why it's shameful that we have no data on pregnant ladies and small children. If the patient doesn't tolerate the regimen, can I give credit for the doses taken? And what would that look like? So these are all questions that we're going to learn. We're going to learn together and we're going to get better at. But I just want to say, if you're going to jump out there, just know that there are some things that you're going to be kind of leading the pack on. And I'm going to throw one last thing out there, since I have had my little snit over the pregnant ladies and the lack of treatment options for little ones. And I will tell you that the SHINE trial, SHINE, has come out and is treatment shortening for small children, and more to come on that. So now, here's the next question. We're still looking at, now we have new drugs and we have new options. Dr. Seaworth, what is it? Is it MDR? Is it XDR? IDK?
So recently, both the WHO and the CDC have changed the definitions of drug-resistant TB. And I'm going to try to bring data on both of those. They're a little bit different, and you can recognize, you'll be able to recognize the differences between the definitions of the two groups. So why are the definitions changing? Drug resistance is increasing. Simple MDR-TB is something that we don't see it nearly as frequently anymore. Just INH and rifampin resistance. Usually it's much more than that. But the good news is we have new drugs that are stronger, less toxic, and we rarely, if ever, use a second-line injectable therapy anymore unless it's for a brief period of time during hospitalization. Its use has been discouraged by both the World Health Organization and the CDC. The new definitions should better support both new diagnostics and new therapeutics. They should support better, shorter, more tolerated regimens, and it's an impetus for more molecular testing and broadening the drug susceptibility testing we have to include many of the new medications. The classifications also let us reflect on which groups have more serious disease and which require different treatment regimens. If we look at how often MDR-TB patients have their isolate tested for susceptibility to fluoroquinolones, we can see it really varies across the world. This was from 2019, published by the World Health Organization, and they noted that in the US, about 50 to 79%, it's probably closer to that 79%, of individuals with MDR-TB actually have fluoroquinolone susceptibility done on their isolate. I would have thought it was much closer to 100%, but that we really need to get closer to 100%. In countries like Russia, Eastern Europe, India, Australia, some places in Southeast Asia, Chile, Argentina, they're up to more than 80% of the isolates tested for fluoroquinolone susceptibility. So hopefully next time we see this map, it's going to be dark purple in a lot more places. The World Health Organization recognized they needed to change the definitions. And so they called together a consultation in October of 2020. Before they did so, though, they gave a charge to the people that were going to be participating in that consultation. And they noted that the new definitions should be simple, should be easy to measure, should be relative to programs. They should tell programs when they had a very serious form of TB, let them look at outcomes. And they, right up front, they said they should no longer include any reference to injectable agents. That should not be part of the definition. And they should be future-proof. In other words, that the definitions they come up with now shouldn't have to be changed in 3 years when they have a few more drugs. So they use group A to designate the drugs that currently are the backbone of the recommendations that we're using: levofloxacin, moxifloxacin, bedaquiline, and linezolid. However, the CDC definitions, when we get to those, you'll note that they include linezolid and bedaquiline. And so as newer drugs become available and move up to be more and more important, the definition is probably going to have to change again. So this is what the World Health Organization did in January of 2021, their new terminology. They previously had not defined pre-XDR-TB, but now they included it as a definition. And there, for WHO, you can have pre-XDR-TB if you have resistance to rifampin and a fluoroquinolone. There's no mention that you really need to have INH resistance, but rifampin and a fluoroquinolone, pre-XDR-TB. For XDR-TB, they changed their definition from including resistance to an injectable drug to resistance to rifampin, a fluoroquinolone, and at least one additional group A drug. Now let's look at what the CDC has done. They updated their terminology about a year after the World Health Organization. They considered what WHO had done, and this is what they came up with for us here in the US. They continued to include pre-XDR-TB as a definition. We'd had it before, and they didn't change it. Pre-XDR-TB is TB that's resistant to INH, rifampin, and a fluoroquinolone or an injectable. So it could be just INH, rifampin, and an injectable drug. And that's really not going to impact how we're going to treat patients because we aren't using injectables, but that definition was unchanged. They did change the definition for XDR-TB. XDR-TB is TB that's resistant to INH, rifampin, a fluoroquinolone, and either a second-line injectable or bedaquiline or linezolid. And let's look at this graphic. It shows it a little more clearly. This is from the CDC communication. And in the red box, you can see that XDR-TB is resistant to INH and rifampin. The X's are there. A fluoroquinolone. And then if you move from across the slide, it can be either a second-line injectable, bedaquiline, or linezolid can qualify as XDR-TB. So if we look at the differences between the World Health Organization and CDC, WHO recognizes rifampin resistance and classifies it as similar to MDR-TB, resistant to INH and rifampin. And that's because basically outcomes are the same, and treatment of rifampin-resistant TB should be very similar to that for MDR-TB. CDC doesn't discuss, recognize, talk about, recommend anything for rifampin-resistant TB. It's like it doesn't exist, but we see it not infrequently. XDR-TB is, as I noted, it only requires resistance to rifampin, a fluoroquinolone, and a group A drug if it's WHO. But if it's CDC, it's H along with rifampin and the fluoroquinolone, and then it can be one of three choices: the injectable, bedaquiline, or linezolid. So a little bit different. And it's important that we recognize this because we're going to be getting XDR-TB patients from other countries. And it doesn't mean the same as it does here in the US, always. So I want to thank you for being here. Thank you for all of you and all you do every single day. To the many of you that have been here working, seeing patients every day throughout the pandemic, you definitely make a difference. And we thank you.
Good morning, and thank you for joining us for the celebration of the World TB Day. My name is Shannon Brown. I'm an RN TB case manager at the Texas Center for Infectious Disease located in South Central Texas, deep in the heart of Texas, San Antonio. I'm glad you could join us today. Texas Center for Infectious Disease, or TCID, as we affectionately refer to our facility, is the last freestanding tuberculosis hospital in the United States. We treat pan-susceptible tuberculosis, multi-drug resistant tuberculosis, and extremely drug resistant tuberculosis in coordination with Heartland National TB Center, public health districts, local and regional health districts. Funding source is general revenue, and though we do try to collect for insurance, our concern is that we treat the patient and serve the public health to make sure that TB is eradicated. Where our goal is working with the regional public health districts, other states, and other countries to eradicate TB and prevent the spread. To that end, we patient-centered care and trauma-informed care at our facility. We are a full-service hospital that functions to provide TB treatment both orally, directly observed therapy, IV, and we coordinate with the University Health System to provide holistic care. Part of our goal is to provide treatment for the whole person. Person-centered care provides patients with appropriate care and treats not just their emotion, their physical, but also their emotional and spiritual. And to that end, we have 24-hour nursing care. We have 3 full-time physicians that are here at our facility. We have recreational therapy, behavioral health, substance abuse, social workers, case managers, and we have a full-time dietitian. This allows us to provide care for the entire person. Person-centered care is important here at TCID because the patients feel more comfortable with the facility. We consult the patient at every step of their stay here. When they first come in, the interviews are done by behavioral health, substance abuse, nursing, so that we can develop a plan of care, a comprehensive plan of care, not just the nursing plan of care, but the plan of care for the social worker, the plan of care for behavioral health. We have a psychologist here on staff who also helps patients deal with their past traumas so that we can move forward to present them back into the community as a whole person. The staff meet the emotional, physical, and social needs of the patient. And this we also feel is important because a lot of our patients come to us with drug resistance because of repeated failures for treatment in the facility, in the community with the health districts related to substance abuse or behavioral health issues. Also, we do have a locked unit for court-ordered patients, and we receive patients from the jails who also have untreated or undiagnosed psychiatric issues that have caused them to repeatedly fail treatment and to become incarcerated. And by providing patient-centered care, we're able to address the behavioral, psychological, emotional, and trauma issues that have been barriers to compliance with care, and to engage the patient as well as their families so that when they return home, sometimes for treatment as long as 2 years, that they are able to function and have a more productive life. We also, with our social workers, identify patients who, because of the long-term effects of TB, may need to have disability applications because of lung damage, or in the case of meningeal TB and strokes that are permanently disabled and will need care. We also work with Cure TB and with the Border Health to return patients back to their country of origins, and that they are able to either continue treatment or to do contact investigations with those countries as well. We also try to improve patient independence, and by engaging them in their care, they're more likely to comply with care and to complete treatment. Hospitals throughout the world right now are extremely strained because of COVID, and we have so many more patients that were late to treatment, and that they have felt that they have been ignored because they've returned to the hospital over and over again with TB symptoms, only to be told they don't have COVID, so they return to the community and they become more and more ill. So they're suspicious of the healthcare system, and many of them are financially burdened. Hospitals are burdened, and patients running up literally millions of dollars in bills because of the lack of identifying TB in a more timely manner. I think it's important to understand that patient-centered care focuses on respect for patients' preferences, coordination of care with integrated treatment, and that would be identifying dietary restrictions such as vegan or vegetarian, providing information and education, not only on the tuberculosis, but also on any other issues and medical comorbidities that they may have. Physical comfort, emotional support, the involvement of friends and family, the continuity of care that they get and transitioning back to home if they're going to go back home with directly observed therapy, and access to care when they leave here, whether they're uninsured and receive insurance, understand what their insurance options are when they return to the community using federally qualified health clinics, or understanding that they will need to have lifelong healthy habits. I feel like TCID is a cornerstone for TB treatment. We are the last stop for many patients, that when they have no other options, and that they might have died when they get treatment at other facilities, because the holistic care and the recognition of the complexity of TB treatment and the willingness of TCID physicians to reach out to not only Heartland, but to our other entities that we deal with and facilities we deal with, to seek the most comprehensive and holistic care for the patients that are admitted here.
Good morning. My name is Jackie. I'm a public health nurse at the City Chest Clinic. Today we'll be talking about patient-centered care. This was first discussed in the literature in 1950, but it took a 7-year-old girl to bring it to the forefront of patient care. Lauren had been hospitalized more than 50 times by the time she was 7. She was frustrated with people walking into her room, poking on her belly, telling her things that were not going to hurt when in fact they were going to hurt. And she didn't like the fact that they stood in front of the TV. She worked with a hospital child life specialist to create a list. And this has evolved into the patient and family-centered care. The Institute of Healthcare Improvement lists 4 domains for patient-centered care: their dignity and respect, information sharing, participation in healthcare, and collaboration. So at our clinic, what we do for dignity and respect, we make sure we address all patients by their proper name and by their preferred pronoun. In our organization, we practice equitable treatment for all people, their families, and even for fellow employees. We use interpreters for patients who don't speak English or Spanish. We also support patients by finding out what their needs are. Social support is very important to our patients when we're going to tell them that they cannot go to work. Many of our patients are from lower social economic status, and so not being able to work is very difficult for them, and asking for help can be difficult. So we advise patients of where they can get help. Sometimes we raid the office for food that we have from the staff. We help them find places that will help them with their rent, or refer them to the food bank. We also provide bus passes or taxi services. We also give patients the option to come to our clinic, or to have someone come to their home to provide them with DOT. And sometimes we even do video DOT with patients. For information sharing, we educate the patient and counsel the patient on the disease and treatment, and how important it is to adhere to treatment. We use TeachBack, which has been implemented to ensure that patients understand what we're telling them. We have a patient portal available where patients can go in and see their labs and information about their visits. We help patients to participate in healthcare. They can discuss their options for treatment. In some cases, our patients aren't able to refuse treatment because they have a contagious disease, but then they have the option of where they're going to be treated. We work with patients to try and mitigate any side effects they might have from the medication by finding regimens they can tolerate, or by adding adjunct medicines such as Zofran to prevent nausea. We collaborate with our patients through patient surveys One of our patients' biggest requests is that our clinic be somewhere else, and unfortunately, we haven't found a way to do that yet. So those are some of the ways that we focus on patient and family-centered care. Thank you.
Hello, my name is Elizabeth Reyes, and I was diagnosed with disseminated tuberculosis, which means it spread through my whole body. On October 24th, 2020, I began to have a dry cough. I went to a local drugstore and received a rapid COVID-19 test. It came back negative. On October 31st, I went to the doctor because my chest and upper back were hurting due to my persistent cough. My doctor diagnosed me with an upper respiratory infection. The medication he gave me seemed to work initially. By November 18, my cough had gotten worse. I was fatigued and having night sweats, which I thought were fevers. So I returned to my doctor. I told him about the symptoms I was still having. Consequently, he still believed I had an upper respiratory infection and prescribed me different medications than I was taking before. On November 30th, I returned to the doctor again. By this time, I had begun vomiting and the other symptoms had gradually gotten worse. The doctor grasped for another diagnostics, this time asserting my distress was due to my allergies. I asked if he should consider a more severe diagnostics, as I was growing increasingly weak. I could hardly walk. The doctor reassured me as he wrote out the allergy prescription. However, just to be sure, I also received x-rays. They came back clear or otherwise negative, yet I still felt terrible. On December 8th, I became so ill I went to the ER. I still felt like I was having fevers and now I was vomiting every time I ate or drank, and this cough was still lingering. I described the details of my illness, history, and my visits to the PCP. The doctor dismissed my fears and diagnosed my condition as a stomach virus. I was given yet another round of medications to help with my nausea, but my cough was not considered. On December 21st, my family insisted that I go to my dad's primary care provider. Maybe he would take my condition seriously. Upon seeing me, he immediately announced I was too critical to receive care in a doctor's office. I felt like I was dying, and I began to wonder if I was. The PCP directed us to go to the nearest hospital for admission. Upon arrival at the hospital, I was the only one allowed to go in due to COVID restrictions. I was so weak, scared, and alone. I felt so vulnerable. No one was there to help me. The ER physician was very stern with me. He told me my symptoms didn't require the emergency room, and without missing a beat, stated a PCP should have been able to treat my symptoms. I felt like he was telling me I was wasting his time and the space I was taking up in the hospital was for other people, not me. However, he finally agreed to admit me with the stipulation that I was only for one night, and it would include observation and labs. I don't remember much of that day, but I would later wake up in the ICU, getting blood transfusions, fluids, antibiotics. I was finally receiving care after all this time, but what was wrong with me? On December 25th, the infectious disease doctor burst into my room wearing a personal protective gear from head to toe. My head was spinning. This really was serious. He was unable to breathe the same air as me. It reminded me of something straight out of the movies. He told me I had an abnormal lab that showed a 0.01% chance of tuberculosis, but not to worry. From this point on, my treatment got considerably worse. I was moved to a negative pressure room. The nurse told me they would provide care every 4 hours and they would be wearing their full PPE. Some of the nurses made me feel like I was lower than them because I had tuberculosis. I felt as if I had one of those deadly diseases that you only read about in school, like the bubonic plague or the Spanish flu. I didn't know anything about tuberculosis. It wasn't until my admission to TCID in San Antonio that I received compassionate care from the doctors, nurses, and staff. They made me feel as comfortable as possible. They listened to me and did not stigmatize me for having tuberculosis. I believe it is because they know more about TB. It was here that I experienced true patient-centered care. I regained my mental, physical, spiritual, and emotional health. I had all but given up after being terribly broken, not only by this disease, but by the providers that were employed to help me. Today, I still have many doctor's appointments to follow up. My last day of TB treatment is April 8th. I have now regained my strength and weight, and I can walk and eat food, and I am grateful that my hair has grown back. I am now counting down the days to discharge and finding my place in the world. I am looking forward to my future without tuberculosis, yet I will forever be changed by my experience.
Hi, everybody. This is Lisa Armitage. I wanted to start off our Q&A session by giving a couple of shout outs. I'm trying to get my camera on so that you can actually see my face. Dr. Seaworth is traveling, so she won't be here with us, but I wanted to start off by just thanking, the speakers, the nurses, Shannon and Jackie, giving some of the feel for what we feel is one of the most important things about what we do, is centering our all of the extraordinary things we do around the people we actually serve. And I want to actually say a huge thank you to Liz for sharing her story and for being so brave. She's been working with us here at Heartland, and she has just shined just a light in our our center here. I also want to say a big thank you. I want to give a shout out to the folks in my clinic. I want to, for all of the things that they are doing, for all of the ways that they show up every day. There we go, and make what we do extraordinary. And I want to encourage all of you on the line to turn to all of your healthcare providers today and give them a hearty thank you. TB has taken a lick. We have been, marginalized. We have had our people snatched from us to go do COVID. We have had just been pushed to the side. And those of you who have been in public health for a while, you hear me. Zika and Ebola and COVID is always something else, and not focusing on our patients who have such a long road that they have to travel. So each of you, I want to say thank you. I have to give a specific shout out to my to my ladies, Norma Santos and Victoria Adams, for providing the numbers for me. I want to encourage everyone to look at your own numbers and see what your cases are doing. We're just seeing an explosion, and I think that needs to be something that needs to be looked at, and we need to call attention to ourselves, find a time to start bringing it back home, bring it back to us, bring it back to the important role that we played in COVID. And now that we need to get back to our own patients and knowing that they're going to be okay. So again, I specifically wanted to say so to the ladies. Dr. Goswami from the CDC sent a link earlier with the information for we're calling it the rifapentine moxicloxacin trial that is now coming into a regimen. So if you get, it has all of the information that I have on the slides kind of spelled out a little bit more specifically. And so I don't see any questions, but I want to, again, like I said, just today, ask you to, let me see, ooh, Nancy Miller raised her hand. Delphina is over on the side. Delphina Sanchez is over on the side trying to keep me honest here. So let me see. All right. Nancy, I unmuted you if you want.
Can you hear me?
Yes, we can.
Okay, you said no questions. That was my chance, right? So I just have one question, and I have to give a shout out to TCID because I don't know what we would have done with some patients that I think would have died if they had not been there as a resource for the region and the local health departments. So I just have to say that real quick. But my question is, are we looking at ways to differentiate COVID radiological effects? Because this seems to be something we've been discussing lately, where we have patients that are culture negative, QFT positives, probably would have been called an LTBI, but we have significant radiological questions, and you probably know because we've been consulting you like crazy for months now. And is there any talk about how we're going to sort some of the COVID effects from possible TB? That's it.
There are a lot of papers now that are showing some of the common lesions that you see with with COVID that are, but the problem is they're not telling you, this is what's different from TB. That's a paper, that's a series of paper that we need to have going forward. So we're just coming out, we're still, coming out of the flames right now. I feel like we all have our hair and our eyebrows on fire. So we haven't really stopped to kind of look behind and see what has changed. So there are papers that show lesions that are consistent with COVID. And when I get consults and I'm like, this looks like TB to me, how could this not be TB? I went and looked at the papers that show the lesions for COVID, and they are very different. They tend to be very different in the presentation. It's a more viral presentation than either miliary or cavitary. There's no cavities in COVID, and they don't have any lymphadenopathy. So there's some things that are distinctly ours, but we haven't gotten to the point yet where we're starting to get the papers where in our literature, where that's telling us what that is. So that's an excellent question.
I think we're all wondering on that one. So thank you. It'll be interesting to see where it goes.
Any other questions? So again, I think we have gone a little bit past the hour, and we have kind of kept some of you a little bit past time. Again, want to thank you for showing. I'm looking for it. Okay. I have where my setup is. I can't see the chat box, so I just wanted to make sure that we have. Sorry. Don't think it's shining a light on me, so y'all can see me. There we go. There we go. So no, we're looking good. So I think if there are no other questions or no one else has any, oh, here we go. It's for me. There we go.
Hey, Lisa, can you hear me?
We can.
Just really quick in response to that last question, it's probably really oversimplified and missing a lot of nuance and complexity, but there is like a really basic table that we put out in collaboration with a local health department, but it's a CDC article as well, and it has a little table that is like the differences between the clinical presentation of COVID versus TB. And I'm going to put the link here in the chat, but I want to put the caveat that it came out early and is probably not, exactly what you're looking for, but just you can look at it and see if it's helpful.
And though if there are some obvious differences, I would say some of the tools that you're seeing that we're mentioning, especially the ones that the CDC are putting out, I would suggest putting, just downloading them. And so when you have providers in your area, especially when you feel so, in your gut, it just tells you that this is TB and you don't have, and they're asking you, well, how you know? Pull some of these tools up and at least share with them so we can get the conversation started in your areas. Because we're, it's still getting down to an understanding that, and I don't know what's changed lately, but I'm starting to see that we're getting a little bit more respect for the health departments and their understanding of what TB looks like. It seems like physicians' heads are so filled with COVID that they don't exactly have enough time to sit down and think that they know everything about TB like they used to. So I tell you, we're your biggest advocates. We're sending them to the health departments left and right and telling them these people have been doing this for years. This is where the centers of understanding are. This is where you need to be going. So any of the tools that you have there, for example, of course, we're always here for you. And for those of you who are visiting with us from other regions, your COEs are there for you as well. But pulling some of these out are going to be some of the tools that you need as we go forward. So hopefully we're going to be able to get something like that. I would love to see just a whole set of papers that tell us not just how the numbers have been affected, not just how many deaths we have, not just how we've fallen short, but also, what the differences are and how people need to look a little bit differently. Mostly, I just hope COVID goes away. That would be it. But I think it's gonna hit endemic in our, it's gonna hit endemic in our country, and we're gonna see cases of it, but we just don't want to lose any more of our TB patients to it. So I see that I am the lone holdup to the CME link. I want to say again to everybody who joined us today. And again, I want to wrap my arms around my entire clinic staff and everything that they do, my Heartland staff and everything that they do. And I want to encourage you to turn to your, I want y'all to turn to your folks that were working with you, and I wanted you to do the same. I got one last question at the last second. Is there a simplified flow sheet for diagnosed and disseminated TB? Really, it's just diagnosing TB. If you get it in one site, once you evaluate your patient, ask them if something hurts. If you have a TB patient, that TB can be anywhere. So Liz, she started off with a cough, and then she started having some abdominal symptoms. Don't ignore any of those. You want to go after every place that the person says is hurting. Back pain could be TB in the spine. Chest pain is usually, cough and some lung symptoms, but abdominal pain could be lymph nodes in the abdomen. Headaches, never ignore a person who has TB telling you that they have a headache. So go after it. There's no flow sheet for it, but the easiest way is to just go after every site that the person shares with you that they have pain with.